pastor just presiding. Please be seated.
Thank you, Deputy Jones. In the case of People versus Conrad Murray, Dr. Murray is present with his counsel, Mr. Chernoff, Mr. Flanagan, Mr. Gorgian, and Mr. Pena. The people by their counsel, Mr. Walgren and Ms. Brazil. Dr. Shafer, once again, is on the witness stand. All of our jurors and the alternates are present. Ladies and gentlemen, good morning. And good morning to the jurors. I missed you, ladies and gentlemen. I told you at the very beginning of the trial that I was going to apologize, and I did apologize for anticipated delays and interruptions, and we certainly had that unanticipated interruption. It was unexpected, and things like that regrettably do happen during cases. We have interruptions. It's been 6 days, I believe, since last we saw you. I'm glad all of you are back. I again want to apologize, seriously. I hope that you were able to be productive during this time frame in terms of taking care of any business or professional related matters or even any personal appointments that you had. But on behalf of everybody involved in the case, I want to thank you for your patience. Again, apologize for the interruption and encourage you to continue being as prompt and as conscientious and as good-spirited as all of you are. So thank you once again. And Dr. Shafer, good morning.
Good morning.
Dr. Shafer, do you acknowledge you are still under oath and still sworn to tell the truth?
Yes, I do.
Thank you. Please remember all of the prior admonitions as well. We're going to have a resumption of direct examination by the people through Mr. Walgren. Mr. Walgren, good morning.
Good morning, Your Honor. Thank you.
You're welcome.
Good morning, Doctor.
Good morning.
As the court indicated, I believe we left off about 6 days ago. And where we had left off is we were going through some of your qualifications in this area of pharmacokinetics, pharmacology, anesthesiology. I had asked you about editorial boards you had served on, and you had named a number of different boards, and actually one had escaped your recollection at the time. What board was that you also have served on?
Yes, I also served as both an associate editor and then an editor of Anesthesiology, which is one of the world's finest medical journals. And when I realized I had forgotten it, I immediately contacted the editor and apologized for leaving that off because it was quite an honor to serve on their editorial board.
And just to have an idea of these types of what these publications are, did you bring with you a copy of the journal, just a representative copy of the journal Anesthesia and Analgesia?
Yes, that is a representative copy of the journal.
And this is the journal for which you are the editor-in-chief?
That is correct. We produce one of those every month.
Excuse me.
While the projector is booting up, let me say that the cover that you see... I'm sorry.
Okay, so just to give a visual of the publication in which you're the editor-in-chief, you indicated this is published monthly?
That is correct.
And about how many articles are included in each monthly?
About 40 right now.
And those represent kind of a broad spectrum of the current research and knowledge in the field?
About two-thirds of them are research reports. There's also a smattering of case reports, commentaries, editorials, and review articles.
And we'd also spoken, thank you, about...
Just displaying the cover. That's the purpose, correct?
Yes, I just wanted, yes.
Can we remove it?
Sure.
Thank you.
You'd also spoken about the package insert for propofol and what your work entailed in regard to creating that package insert. And specifically, it was my understanding that you worked to create all the modeling and simulations that were relied upon and are still relied upon as to the correct dosaging of propofol?
For sedation specifically, both the monitored anesthesia care type of sedation and also sedation in the intensive care unit.
And again, the monitored anesthesia care type of sedation, that's commonly referred to as MAC, M-A-C?
That is correct.
And could you just kind of briefly describe the difference between MAC sedation and intensive care type sedation, if there is a difference?
There is a difference, and that is an intensive care type of sedation. In intensive care sedation, patients typically need to be sedated for very long periods of time. Often a patient will be in an intensive care unit for days to weeks. And so in the intensive care unit, one is looking often for sedation that might follow the usual cycle of a day, 12 hours of sedation, then 12 hours of lack of sedation. Also, patients are essentially continuously bombarded in the intensive care unit with light, with medications, with procedures, and they need something to take the edge off of that experience. It's very different than the kind of sedation that a patient would require, say, to undergo some small operation on your hand, where they would give you a little bit of sedation, the surgeon would inject some local anesthesia, and with the sedation and local anesthesia, you'd be sleepy for an hour or so. So that's the first kind is intensive care unit sedation, long periods of time, often in patients who are critically ill. The second kind of sedation, the MAC sedation, is typically for minor procedures where it's important that the person be sleepy for a small period of time.
Now, you also had begun telling us about some of your research and publications in the field specific to propofol. And just to give us an idea of your area of publications in regard to propofol, I just want, if you could, I have an article here entitled, and I'll put it on the screen so you can see it. The influence of method of administration and covariates on the pharmacokinetics of propofol in adult volunteers. And this is your name here, Stephen L. Shafer, MD?
Correct.
And if you could, in just kind of simple terms, so we have a better understanding of this field, what did this individual representative publication involve as far as research and findings?
This was a volunteer study which was intended to examine three questions. First, let me just step back and say, you remember pharmacokinetics I described as drugs in motion. The question is, what happens to drugs after they go into your body? You would think, just to look at people, that there might make a difference if you were large or small, or it might make a difference if you were a male or a female, and it might make a difference depending on your weight. Maybe when a drug is given to a large person, the drug kind of has more places to go, so the concentrations are not as large. If the drug is given to a very small person, maybe you should reduce the dose. So what this study looked at was, what is the influence of gender? What is the influence of a patient's weight? And perhaps most critically, what is the influence of age on the pharmacokinetics, on the drugs in motion? And there's a conceptual way of thinking about it, sort of drugs in motion, but you actually, to use it, you have to reduce it down to math. You have to reduce it down to specific mathematical models where you say, I'm going to give this number of units, and this is what I'm going to see in the patient. And that has to be a mathematical relationship. So this study created that mathematical relationship that allows you to incorporate what you can measure in a patient to get the prediction as accurate as possible.
And
And
we'll,
I think we could remove the actual face sheet
I
at this
will,
point.
yeah.
Thank you.
showing you another article, Dr. Shafer, entitled "The Influence of Age on Propofol Pharmacodynamics." Again, with your name, Stephen L. Shafer, MD, is one of the authors of that article. Can you describe for us the basic research and findings in regard to this publication?
Yes. So I was the principal investigator on both of these publications.
What does that mean?
Oh, sorry. I was the responsible scientist that was responsible for the protocol, responsible for the study, and responsible for the analysis. These are the same patients. But now we're talking about something called pharmacodynamics. Pharmaco, remember, means drugs, like a pharmaceutical company. Dynamics means power. It comes from the Greek word dynamikos, I think, but it means power. So this is about the power of drugs. How powerful is a drug? And it addressed the same question. How does age, gender, weight, but most important, how does age affect how powerful the drug is in the body? Is the drug more powerful in the elderly patient, making them at risk? So it's the same patients as the earlier study, but now it's a different kind of mathematical model, a model that relates the concentration of drug to the power of the drug in the patient. How strong does the drug appear to be?
Thank you, Doctor. Another article, Doctor, entitled "Propofol Dosing Regimens for ICU Sedation Based Upon an Integrated Pharmacokinetic Pharmacodynamic Model." Again, with your name, Stephen L. Shafer, as one of the authors of that article. Again, can you describe that article, the research and the findings?
So again, I was the principal investigator, which means this was my study. I was responsible for the conduct of the study and for the analysis and presentation of the data. In this study, we brought those two papers you saw before. There was one on pharmacokinetics, which was drugs in motion, and one on pharmacodynamics, which was drug strength. And they were separate papers because it was very complicated. In this paper, they're all in one paper. So we have both the study of what happens to propofol in the intensive care unit in terms of how a dose leads to a certain concentration, and we have the other piece, which is how does that concentration give you a drug effect? How does the drug manifest its power? And the key question here is, are intensive care unit patients different? Because they're critically sick. Are they different? And this study was, in fact, the study that was used by the Food and Drug Administration to generate the dosing guidelines for propofol when used for sedation in the intensive care unit.
Thank you, Doctor. And we will be discussing the application of this research to this case. I want to go over a couple other articles with you. Have you also done research specific to lorazepam and midazolam?
Yes. We looked at lorazepam, which is a drug like Valium.
Well, yes, and you can explain. Overall,
We've looked at lorazepam and midazolam. Both are Valium kind of drugs, and they're used in the intensive care unit. And we established the same kind of mathematical models. Because to use this research, you have to have mathematics that comes out of it. So you can actually calculate what happens when you give a certain dose of the drug. So yes, I have.
And putting up on the screen, see if I can read this title, a double-blind randomized comparison of IV lorazepam versus midazolam for sedation of ICU patients via a pharmacologic model. And again, your name, Stephen L. Shafer, is one of the authors of that article.